Hi, my name is Jackie, and I am a nursing student at Aspen University. Today I'm going to be teaching you a little bit about GERD. GERD is a symptom that occurs when the stomach acid no longer stays inside the stomach and it gets regurgitated or refluxed up inside the esophagus. This is why it's called gastroesophageal reflux disease. Now, this can occur due to several different reasons. The most common reflux is due to the lower esophageal sphincter becomes incompetent or too weak to stay closed. Normally, it stays closed, allowing the stomach acid to actually stay within inside the stomach while it is breaking down, and then gets flushed out whenever it is ready down the duodenum and into the rest of the body to get reabsorbed. When the LES becomes incompetent, what occurs is the LES, or lower esophageal sphincter, fails to close, and then stomach acid comes out of the esophagus or out of the stomach and into the esophagus. Now, the esophagus lining is not meant to actually have the pH balance of the stomach acid inside of it. If the stomach acid actually touches the esophagus, it can cause esophagitis, which is a chronic inflammation of the actual esophagus. If the esophagitis is not taken care of, it can cause striders, it can cause scarring, it can cause dysphagia. It can also turn into Barrett's esophagus, which is a precancerous condition. And if that is no longer taken care of, it does turn into esophageal carcinoma, which is a cancer. Sometimes the stomach acid goes up even higher inside of the actual esophagus. It can get into the respiratory system, and when that happens, it creates the laryngeal spasms, the bronchial spasms. It can create a cough. It can cause asthma, chronic bronchitis. It can also cause pneumonia. If it keeps going up even higher, it can get into the back part of these molars right here, creating dental erosion. Another reason why the stomach acid would come out of the stomach is called a hiatal hernia. And now this is where part of the stomach actually comes and is protruded above the diaphragm right here. So when stomach acid comes up, it kind of comes up and gets stuck right here inside of the outpouching of the stomach that's above the diaphragm. And then it can freely go up the esophagus whenever, causing the complications that we previously talked about. Reasons that the LES actually becomes incompetent usually is due to increased abdominal pressure. It can be caused by obesity, it can be caused by pregnancy, it can be caused by foods that produce or induce acid production. Smoking, along with it, can weaken the actual LES, and certain medications can also weaken the LES as well. Especially, this is why we teach our patients when they do the anesthesia for procedures not to have anything inside their stomach at least 8 hours prior to, because it affects the lower esophageal sphincter enough to where anything that is inside the stomach can go up the esophagus and into the lungs, and then they aspirate. So medications can affect the lower esophageal sphincter. For signs and symptoms of our patients, the most common complication or most common clinical manifestation that you'll actually see in these patients is heartburn. It will usually be described as severe. It occurs right after they're done eating, which is a big sign as to it is heartburn and not anything else. Because sometimes the heartburn can mimic angina, which is that chest pain, giving a squeezing sensation, the radiating to the back, to the arm, to the jaw, to the neck area, and to the arm, which kind of sometimes gets confused for heart problems when it is a GI problem. We typically tell our patients, go ahead, take an antacid. If the antacid actually doesn't resolve it, then it's probably heart related. If the antacid takes care of it, it was probably GI related. So knowing what is actually going on with our patients and their signs and symptoms kind of help tell us what is going on with our patients. The heartburn can also wake our patients up in the middle of the night due to the stomach acid coming up, and it usually occurs more than twice a week in order to actually be diagnosed with GERD. Other signs and symptoms are dysphagia, so that painful discomfort feeling, regurgitation. A lot of times people say it tastes hot, sour and bitter. They can have an increased saliva production. Also having like a choking feeling, like they're choking on too much of the saliva, or maybe a choking because they can't clear the actual airway. Um, let's see, if they have, again, with the respiratory system, a cough, they can have wheezing and dyspnea. It can make their their vocal cords sound very hoarse, a hoarse sensation. It makes it feel like there's a lump inside their throat, a sore throat sometimes as well. And it can, let's see, oh, no, I got it. So yeah, it can sometimes make it feel like there's this huge lump, and it's usually due to like the inflammation process. Ways that we diagnose our patients is using the clinical manifestations and the reaction to therapy. So if we tell them to take an antacid and we can kind of figure out that's what's going on, well, if it occurs more than 2 to 3 times a week, chances are, come on in, you probably have this. Let's go ahead and do some more diagnostic studies, which then include the upper GI endoscopy. This comes down and investigates how the LES is actually doing. It looks to see if there's any inflammation inside the esophagus. It looks inside the stomach to see if there's any ulcerations inside the stomach as well. If it needs to go any lower, because sometimes the duodenum can sometimes have ulcers that kind of mimic what the GI actually, or the GERD is making the stomach feel like. So they'll do a duodenum endoscopy, which they'll come down up here and then into this area. They can also take biopsies at this time if there is something in there that they feel like they need to take a biopsy of, and just to make sure it is not cancer. Let's see. Patients can also have what's called an ambulatory esophageal pH monitor. So what that is they'll take like an NG tube, stick it down your nose, and they'll stick it right inside the stomach. The bottom of the NG tube comes up and above your ear and into like this little monitor system. And it monitors the patient's acid production for 24 hours. When the patient's done, they'll come back. We'll take the tube out and read the monitor and see exactly what's going on within a 24-hour span. One important thing to teach these patients on the actual HP balance is to eat a normal diet. Don't do lifestyle modifications and take your medications, because we want to see exactly what your pH is doing, not what your pH would be doing if you were doing what we need you to do. So having them do a typical day is key in teaching our patients about the 24-hour monitoring. Radionuclear tests can also be done too, and this is to pretty much test the patient's rate of esophageal clearance. Like I said, sometimes the esophagus becomes so inflamed that food can sometimes get stuck on there. And we want to make sure that we are clearing that airway so that our patients are not at risk for aspirating. Treatment options for these patients are obviously going to be lifestyle modifications, medication therapy, and also we can have surgery for our patients. The types of surgery that we actually have is called a fundoplastification. I'm sorry, I can't say the name. This is where we take the top part of the fundus and we wrap it around the LES and we sew it to kind of strengthen the lower esophageal sphincter. But surgery is not the first go-to. Surgery will occur if lifestyle modifications don't work or if medication therapy doesn't work as well. It's usually one of the last of the invasive procedures. Another type of procedure that occurs is called a LINX, L-I-N-X. It's a magnetic system where they stick magnets inside the lower esophageal sphincter to try to help strengthen the actual esophagus. Now they say that the magnets are strong enough to hold it closed, but they do open enough to allow the food to kind of come in. One of the most common complications though of that is it not opening, so then you get food stuck inside the esophagus, which is another risk for aspiration, because if it doesn't come in, it can come out. And we don't want it to get inside the lungs, because then that causes more complications. With our medications for our patients, they can take proton pump inhibitors, H2 blockers. We have our antacids. There's cholinergic drugs and protonactic drugs. Sometimes there's the anti-ulcer drugs as well. I'll educate a little bit more about those in a minute. When it comes to lifestyle modifications, lifestyle modifications is usually the biggest treatment for these patients. And the reason why is because sometimes that's all they need. Sometimes that is the thing that is just going to be taking care of everything. So, as nurses, it is important for us to educate and stress lifestyle modifications. Things that we can educate our patients and especially use interprofessional care on is diet. We want to make sure that we teach our patients alkaline diets, so low acid diets, low fat diets, not to eat or drink anything that's fatty or fried. Make sure to reduce their caffeine intake. Stay away from coffee, tomatoes, tea, milk, orange juice, soda, alcohol. We want to make sure to teach them that alcohol is acidic, so it would not make their condition better. It would actually make it worse. So unfortunately, reduce alcohol, cut the alcohol out if they can. Stay away from peppermint, chocolate, fatty foods. I know everything sounds delicious, so this is really hard for our patients because a lot of times when we try to teach our patients to do a low alkaline diet, they say, well, wait a second, everything has acid in it. So you're pretty much telling me I can't eat anything. No, there are certain foods they can't eat. And they can have certain things in modifications depending upon how bad their actual condition is. But they shouldn't be eating it all the time. One thing we want to teach them about our diet. Oh, and if they have complications with their diet as well, because it is kind of hard to create meal plans from it, we can refer our patients to dietitians to help them create meal plans that are low fat, low acid, acidic diets. We want to try to teach our patients though not to eat and drink anything 3 hours prior to actually laying down, because that gives the stomach time to actually empty before they lay down, and to not to lay down at least 2 to 3 hours after they're done eating. Plus, we want to teach them to eat very small, frequent meals. Small meals don't allow the stomach to become distended, which then increases the abdominal pressure, which actually causes acid reflux to kind of come up. With the increased abdominal pressure, we want to make sure to teach them about that because tight clothing can increase the abdominal pressure. So we want to teach our patients to avoid tight-fitting clothing. We want to try to see if we can reduce their weight as much as possible to try to reduce that increased abdominal pressure. Now, this is kind of one of those, it's good to an extent, but then it becomes bad. If they overwork out and they do too much in strenuous exercises, well, then they're defeating the purpose of actually decreasing their abdominal pressure because they're just increasing it by straining, which can cause complications as well. Increase acid production. So we want to teach them to try to reduce their weight, but do it in a slow manner without increased strenuous exercises. We want to teach our patients to raise the head of the bed. They should raise the head of bed at least 4 to 6 inches with blocks. If they can't do it with blocks, then what they need to do, or they can do, is get a wedge pillow. And the wedge pillow will help them stay at the 30-degree angle that they need to let gravity help keep the contents inside the actual stomach content inside the stomach. And also stress management. We need to teach our patients stress management because stress can also increase acid production as well. When we do the stomach acid, we want to assess the patient for their coping mechanisms. We want to see how they actually cope with stress. Is it a healthy way of coping? Is it not a healthy way of coping? Because remember, we need to teach our patients they shouldn't smoke. And a lot of patients do use smoking as a coping mechanism. And that can weaken the LES and creating the acid content to go back up. So we need to teach our patients that they need to stop smoking. If they have complications with stop smoking, we can refer them out to community resources to kind of help them with that as well. Let's see. Then what we need to teach our patients, or what we also can do for our patients, is assess our patients' feelings. We need to have them share at least their concerns and their feelings regarding the lifestyle choices, because a lot of this is really hard to do, and especially when you're trying to tell a patient that they need to do this in order to prevent further complications. You know, not everybody's going to want to try to adjust their diet or give up their favorite foods just to, prevent acid. They'll try to wing around it, or they do it for a while and then, oh, I feel great, and they go back to this. Unfortunately, with this condition, though, it's kind of one of those lifestyle things that you're going to just end up doing for pretty much your life. It's not until your symptoms go away. And that's one big thing that we really need to teach our patients too. It's not just until your symptoms go away. You need to do this for the rest of your life. If lifestyle modifications do not work, then we can teach them about medication therapy. One thing, the most common medication that you'll normally see are the proton pump inhibitors. This is usually given to patients that go into the hospital to try to prevent stress, ulcer, proliferation that usually kind of somewhat occurs. One thing that we do need to teach our patients, though, if they do take it, at least in the hospital, it can increase the risk of C. diff. And then also on top of it, if they take proton pump inhibitors for a long period of time, it can cause osteoporosis to occur as well. So we want to educate our patients to take vitamin D supplements and calcium supplements along with it to try to prevent that osteoporosis later on. We teach our patients the rationale behind taking these, which is it decreases the hydrochloric acid by inhibiting the proton pump by releasing hydrochloric acid. And then we teach them side effects as well. It can cause a headache, it can cause abdominal pain, nausea, vomiting, flaccid, and diarrhea as well. Well, then our next medication that we want to teach is our proton pump inhibitors, H2 blockers. The H2 blockers blocks the histamine from actually creating the hydrochloric secretion. And we want to teach our patients for that one that it can do headaches, abdominal pain, constipation, and diarrhea. Now, for both the proton pump inhibitors and the H2 blockers, we need to teach our patients to take the medication 30 minutes prior to eating. Not after, not while they're eating, 30 minutes prior to eating. And this is the reason why is because it actually typically takes about 30 minutes for your actual medication to break down and become effective within inside the body. So you don't want to take the medication any sooner than that or any later than that, because then you're going to have a low pH stomach and no food in it, and it's not going to work when you're actually going to need it. Other things that we can teach our patients, is our antacids. So with antacids, they're very short acting. They don't last very long. And there are several different types of antacids that we actually need to teach our patients about. And the best way to remember that is with the acronym SCAM. So you have your sodium bicarbonate antacid, your calcium carbonate antacids, your aluminum hydroxide antacids, and then your magnesium hydroxide antacids. All of these are very short acting. They should be, none of them should ever be taken with any other processed medication. The reason why is because it decreases the actual stomach acid. It acts like a neutralizer. And when you take another medication, it pretty much slows the process of the breakdown of the medication, cutting the medication in half. So you only get like really half of the therapeutic range of any other medication that you're actually going to be taking. So educate our patients. Do not take any other medication with your antacids at least 1 hour prior or right after taking an antacid. You should not also take an antacid you should take an antacid 1 to 3 hours after a meal and before bed. We want to teach our patients that with the aluminum and the calcium antacid that it can cause constipation, but it can also cause milk alkali syndrome as well. And then this can increase your risk of developing calcium stones. You want to teach your patients with the magnesium that it can cause explosive diarrhea. So it's very important to that and these can kind of, So that's where you want to teach them on those medications. Other things that we want to teach our patients, at least when it comes to the diagnostic studies along with the actual surgeries themselves, is we want to teach them pre-operative instructions and post-operative instructions. For the diagnostic studies and for surgeries, we need to teach them how to do a bowel prep. And that's pretty much flushing out the system to make sure there's nothing in it. So nothing inside the stomach goes up when we stick our patients under sedation, or there's nothing inside the stomach when we actually, because we do need to stick them under sedation for the endoscopy. So again, that anesthesia can make the lower esophageal sphincter weak and relaxed. So if you had anything inside your stomach, it goes straight up to the esophagus, and then the patient is at risk of aspirating. We also want to teach our patients post-operative instructions, as well as monitor our patients for post-operative complications. Complications that can occur is a fever, which can indicate that they have an infection. Rebound tenderness as well. Rigid board-like abdomen, increased pain, tenderness, restlessness. We want to monitor their heart rate as well as their respiration rates, because increase any of those can indicate complications. The most earliest sign though for complication after any procedure or diagnostic study is a fever. Anything above 100.3. We also want to make sure that we watch our patients for any signs of bleeding. They can have pneumonia from this, perforations. Sometimes it's very rare, but it does happen. The upper endoscopy scope can actually touch the lining of the esophagus, causing it to kind of like cut the esophagus. So then you have injury that we need to watch out for on our patients, as well as bleeding. And then we need to monitor our patients' electrolyte imbalance as well with this. When it comes to the nursing plan, obviously we need to assess our patients, see what their signs and symptoms are, make sure that it is related to the actual GI system and not heart related or respiratory related, or sometimes even allergies can cause an increase of nasal production down here, which then kind of irritates the back of the throat, giving some of that sore throat, lump filling, hoarseness, and all that other stuff too. So monitoring our patients' signs and symptoms, knowing exactly, does the pain hurt or heartburn hurt before you eat, does it hurt after you eat, kind of helps the nurse figure out what's kind of going on with the patient. Then we need to come up with a plan for our patient by diagnosing them. These patients are at risk for aspiration because of the weakening of the LES, or ineffective airway clearance as well, because they can sometimes get the food stuck in there due to the inflammation process. They are at an acute pain due to that heartburn because it is very severe filling. Also, they are at ineffective health maintenance if they don't comply to their lifestyle modifications or understand the lifestyle modifications too. Sometimes these patients aren't educated all the way. Then we can go on to create goals for our patient. Be like, hey, let's try to reduce, because this is really hard to do. You can't tell a patient, hey, all of a sudden you got to have a low alkaline diet by tomorrow. A lot of times they're going to need to work at it and educating them, this week we're going to cut this, and this out, or we're going to cut it all out, but you're only allowed to have this and this just right now, or something like that. And we can kind of reduce it to where it makes their diet a little bit more gradually easier to work into versus trying to throw them into it, because a lot of times, just like the smoking sensation, you're just thrown into it, it fails. They don't know. You need to educate these patients on what to do, how to do it, refer them to dietitians, refer them to people that can help them stop smoking. Support groups is a big one. And then, your stress management, get them over to somebody who can help create some coping mechanisms for these patients. That could be a plan right there. Let's come up with 3 different coping mechanisms that's actually going to help you reduce your stress levels so that you're not stressed out all the time. Let's, try to see if we can work out at least 3 times a week instead of, sitting on the couch all the time. Coming up with little tiny goals like that can kind of help these patients get pushed in the right direction. Then we need to educate our patients for our interventions. Education is going to be the biggest intervention as much as possible for these patients. Educating them about lifestyle modifications, about the procedures, post-op, pre-op, the diagnostic studies, about the medications, the rationales for medications, the side effects of medications. And then our biggest thing is just evaluating our patients, making sure that they understand, having them actually teach us back some of these things to make sure that they got all the information that we wanted them to do, having them do journals so that it can be like, okay, my acid was really bad this day, but this is what I ate and this is what caused it. Because we want to make sure to teach our patients also, stay away from foods that trigger the acid production as well. If you can eat chocolate and it doesn't trigger your acid, that's amazing. If you eat chocolate and it causes severe heartburn, stay away from it. But you don't really know unless you actually have a food log. So educating our patients about food log and then reviewing it with them later kind of helps to evaluate if our patients were actually effective at, finding their triggers as to what produces their acid, making sure that they found some coping mechanisms that actually work with them to help them to reduce their stress. See if they are cutting back on their actual smoking production and things like that. Hope you learned something today. Thank you very much for watching.